Sridhar S presenting on evaluation and treatment of hypertriglyceridemia. Please join us in welcome Dr. Sridhar S.
I have pleasure of welcoming Dr. Sridhar. He is from Department of Endocrinology, Madurai Medical College, Madurai. Welcome to Mangalore, sir. And I invite sir to speak on the topic. Over to you, sir.
So good morning, one and all. At the outset, I would like to thank Dr. Ganesh as well as the EndoDiab team, and thank you, chairpersons. And it is a great pleasure to be here. And I will be discussing regarding the evolutions and treatment of hypertriglyceridemia. And I will be starting with a case, 45-year-old man with routine mastocytal checkup found to have high triglyceride of 400 milligram and total cholesterol of 230 with LDL of 120. Otherwise, whenever we come across any high triglycerides, we should always to look for any secondary causes like obesity, smoking, alcoholisms, and any family history. That also more important. And any family history of premature CAD. That also it is one of the important things. And his BP was normal and BMI of 28 and waist circumference of slightly higher side. And glucose level is normal with the normal thyroid and renal functions. So how to proceed this case of non-diabetic with euthyroidal and eucortisolic normal other secondary causes were ruled out. So this is the well-known classifications, that is a Fredrickson classifications, but less commonly used after this genetic error has happened. So among these Fredrickson classifications, the most common is a type 2B, that is commonly associated with high total cholesterol with high triglycerides. That is the Fredrickson type 2 classifications. And type 2A, that is again second more common, and 4 and 5 and other things are very rare, and the first one is also very rare, and it is more commonly associated with the hypertriglyceridemia of very severe, more than 1000. So any triglyceride of very severe, more than thousands, most of the times it is predominantly genetic, and however the more common one is a 2B, that is a combined hyperdyslipidemia. So the mild to moderate may be less than 500 or less than 1000. It may be a mild to moderate, and more commonly with the familial combined hyperlipidemia, and less commonly the other situations. And this is a complex slide, but still just for the understanding the pathophysiology and the drug management, the triglyceride we come across two different sources. So one of the source is from the gut or the small intestine, from the dietary sources, and another one is the endogenous productions from the liver, and from the gut it is through the chylomicron, through the lipoprotein lipase. So this is one of the very important enzymes, lipoprotein lipase. It do the triglyceride metabolisms, and whenever in uncontrolled diabetes also is one of the more important cause of hypertriglyceridemia. So whenever the insulin requiring diabetes or uncontrolled diabetes, these lipoprotein lipase levels will be low or it be more utilized, and so insulin basically activate this lipoprotein lipase, and subsequently it decreases the triglycerides, and other enzyme is a hepatic lipase. So the two more important reasons are the sources are from the gut as well as from the liver. And so the dietary things we can do it from the gut level, and some genetic things we have to do at liver or various enzymes parameters. And when to do triglycerides estimations? This is one of the more practical questions, whether fasting or non-fastings. But because of our convenience or patient's convenience, many of the times we may do the random or non-fasting triglycerides. But usually depends upon the genetic backgrounds, it varies, non-fasting. So whenever we want to have very accurate triglyceride estimations, fasting is the best or gold standard. It has to be done at 10 to 12 hours per fast. And normally the triglyceride may increase up to 40 milligram per deciliter 2 to 6 hours after a meal. But in impaired triglyceride metabolisms, like people of genetic background, there may be more than 4 times Still it may be a normal, but there may be more expectations of triglycerides we may come across in such situations. And the levels of non-fasting triglyceride reflect the TG rich lipoprotein. The abbreviation is a TRL. That is many of the papers here using these abbreviations. And ideal non-fasting should be less than 200. So whatever data currently available, most of the data is from Western data, and it is not from predominantly the South Asians or Chinese, because we are more of carb eaters, and definitely the non-fasting triglycerides will be higher in Asian as comparing the Western, but there is no robust or guidelines recommendation is there, do the thing. But for the fine aspect or very accurate levels of predictions, fastings will be the best one. So the types coming to it is a primary or secondary. So predominantly it may be the secondary. Primary, predominantly it may be inherited, but it is quite rare. And secondary causes we may be seeing due to the increasing prevalence of obesity and type 2 diabetes. And among the nutrition causes, so a lot of concerns may be in the fructose. So the high carbohydrate or high consumption of sweets, there will be increase in triglyceride levels also. And other secondary causes like hypothyroidism, nephrotic syndromes, and pregnancy also there may be around 200 to 300 milligram of increase in triglyceride we may expect. And the drugs, so among the important drugs that can cause high triglycerides are oral contraceptives and dermatological agents like isotretinoins and anti-infective agents like anti-HIV therapy, L-asparagines. And some amount of triglycerides may be elevated in beta blockers and antipsychotics, and rarely may be thiazide diuretics. And you can see that there are various the lipid lipoprotein components, and you can see that the ideal VLDL and chylomicrons, they have more of triglycerides as comparing to the HDL and LDL. So more commonly we do the only the normal or fasting lipoproteins, and we don't do this apolipoprotein A or B in our day-to-day clinical practice, and so we have to move in a longer way to assess these lipoprotein particles, and it will give more accurate estimations of the percentage of the triglycerides in various chylomicrons and VLDL. So in very high triglyceride individual, this non-HDL cholesterol, and it is becoming more commonly used, it is total cholesterol minus the HDL cholesterol. It may give more estimations about the residual cardiovascular disease risk. So with this background, one of the two couple of cases, one of the male with the 35-year-old alcoholic during acute pancreatitis workup found to have very, very high triglycerides of around 2,500. And so the triglyceride and HDL will go in opposite direction. So whenever we high triglycerides, HDL will be coming low. And another lady found to have during pregnancy with the triglycerides of more than 3,000. And many of the times the lab technician is the person's, he pick up the samples and triglyceride estimation. So you can see that it will be a lipemic serum. So whenever the serum is like white, definitely the triglyceride level will be more than 1,000, and more than 2,000 or 3,000 also it is more common. And so the even simple looking at the sample, we can able to tell, and triglyceride is very high, and it is predominantly the genetic causes. And recently a lot of genetic conditions also been diagnosed because of the genetic test is becoming available easily, and it is cost economic also because they have to be on lifelong follow-up and lifelong medicines. And familial hyperchylomicronemia, and as already told that the lipoprotein lipase mutations has been an important part, and there may be a polygenetic also. And the hypertriglyceridemia can present to the various specialty, and ophthalmology there may be a lipemia retinalis and mood swings and cardiovascular systems presentations, and more commonly is a pancreatitis. And so one of the important workup pancreatitis is a lipid profile, and there may be a hypercalcemia, that is from endocrine perspectives. And dermatologists, there may be a xanthomas, eruptives and tuberous xanthomas, and there are also one of the more common clinical clues. So clinical suspicion is a very, very important whenever any dermatological manifestations it is there. And you can see that the severity of hypertriglyceridemia classifications, and almost most of the guidelines, if it is more than 500, it is more commonly associated with very severe, and some may more than 1000. So if it is less than 500, then there is a no acute risk, but if more than 500, the pancreatitis risk is very severe, and we have to definitely treat, and we have to keep follow up, since the pancreatitis ultimately they may go for necrosis and diabetes, and the complications of pancreatitis will move further. So triglycerides has to be given more priority in severe variety to avoid the pancreatitis as comparing with cardiovascular system. And so what is the current evidences regarding the triglycerides and CV risk? As already told that there is a residual risk is there beyond normalizing the LDL cholesterol. So LDL, everyone knows that there is a linear relations between the reductions as well as the CV benefit. But after LDL, there is a residual risk. So among the residual risk, there may be ApoB, TG, lipoprotein small a, HDL and other things. And there are some data are coming up that very high triglycerides is associated with increased ApoB, and vice versa. There is a low HDL and decreased ApoA1. So the ApoB and ApoA ratio, and there may be a good correlations that the residual risk people, we have to address these triglycerides also. And very high triglycerides, it's not more CV risk, but the borderline category, around 300 to 500 of triglycerides, it is consistently associated with more and more cardiovascular events. So we have to focus it, these moderate triglycerides for the cardiovascular benefit, whereas the severe triglycerides is more in favor of pancreatitis benefit. And so as already told that the ApoB and ApoA ratios are more important for to manifest the various beneficial effects. Coming to the management, and so the lifestyle has some amount of role in effective triglyceride reductions, and one of the major important things is the weight loss. So the 10% weight loss reduces the triglycerides around 10 to 20%. And similarly, the dietary modifications and plant-based proteins or unsaturated fat. Again, it has more important role, and Mediterranean diet or medium chain triglyceride oil in moderate amount. And exercise again definitely has important role in reductions of the triglyceride levels. So in morbidly obese individual with moderate triglycerides, the weight loss, diet and exercise has some amount, maybe around 10 to 20% of reductions of the triglycerides. So it has to be incorporated in our day-to-day practice. And coming to the pharmacological agents, these are the most commonly available agents. Statins. So statins weight reductions is depend upon the intensity of the dose we are using. The moderate intensity statin or high intensity statins. And here is whenever the triglyceride level is very high, the reductions is going to be more. So always start with higher intensity statins whenever we want to reduce the triglycerides, and that dosage percentage of reductions of triglycerides may be around 25 to 45%, and minimal reductions can happen with the statins whenever the triglyceride of less than 150. And fibrate is one of the most important drugs that has most potential of reductions of the triglycerides, maybe around 30 to 50%. And niacin, that is a nicotinamide acid, and it has reductions of around 30%. And omega-3 fatty acids, some studies found more percentage of reduction, some they have less reductions. And fenofibrate, this is the different strengths available in India, 145, 160 and 200 milligrams. So almost we can use it whichever way comfortable and convenient, and this is one of the most important agents in addition to the statins, one of the best agents to reductions of triglycerides. And omega-3 fatty acids, so it is the long chain PUFA, or the combinations of the EHA and DHA, that is a eicosapentaenoic pentoenoic acid and the docosahexaenoic acid. So the combination of this EPA and DHA, that is the best one to reductions of triglyceride rather than the any single preparation is available, and the dosage of 3 to 4 gram, and many studies they found around 25 to 30% reductions of the triglycerides by reducing the hepatic productions, as already delineated in that picture, that the liver is one of the major important source of triglycerides. And the niacin is available is a 1 gram in India, and this omega-3 fatty acids also is available in various formulations, but up to 2 to 4 gram per day we can use it, depending upon the dosage regimens. By summarizing the pharmacological treatment, so the fibrate is one of the most important things, and vitamin D should be replaced whenever vitamin D deficiency. If any myopathy also has to be closely followed up, and statins, nicotinamide, the combinations also will be very good. So nicotinamide, if uncontrolled diabetes, some amount of minor risk is there, but otherwise well controlled diabetes, nicotinamide is not contraindications to use in triglyceride individuals. And there is a very rare conditions, the emergency management of very severe, since most of the physicians may manage the pancreatitis also, and so these are the some of the things. Whenever the triglyceride of more than 1000, the most of the drugs may not be working, and so you have to go by other managements. So among the other managements, the fasting, insulin infusions, heparin, plasmapheresis, and exchange transfusions. So the most of the acute pancreatitis, by keeping nil oral itself, many of the triglycerides will come down, and you can see that the first day may be around 3000, by second day 1000 or 1500. So the fasting itself will give very important things to reduce the triglyceride in very acute severe conditions, and the mechanisms as already told that it is from the gut. So the small intestines we are keeping some rest, so there is production is becoming stopped, and adequate hydrations and fat reductions diet we have to again consume. And insulin is one of the most important hormone that activate the lipoprotein lipase, and it accelerates the triglyceride degradations into the fatty acids, and it promotes the excess triglyceride stores in the liver as well as the adipocytes. And so the insulin is an anabolic hormone for avoiding the severe hypertriglyceridemia. So you can give insulin infusions and simultaneously you give dextrose in a non-diabetic individual, so that this triglyceride part is very well managed. And so it is important to maintain euglycemia and closely monitoring in ICU care with the insulin dextrose infusions. And heparin, it is not recommended, but it has been theoretically been advised or it has been promoted, but since it is a reborn will happen by using heparin as activating the lipoprotein lipase, but it is not been recommended in anywhere in current situations. And if adequate setup is there, nephrologist backup or other thing is there, then you can proceed for plasmapheresis in very deep. But all the things are very acute management. We cannot do plasmapheresis in a longer run. So the medical management in current situation, it is the only option. So the future severe hypertriglyceridemia therapy, there is one of the PPR alpha and pioglitazone also some amount effect, minor reductions can be expect, and the PIMA fibrate. So this is one of the future therapy, and other things it may take a long times to come to India, but there are very intensive workup is going on for this severe hypertriglyceridemia therapy, and this is one of the promising agents in RCTs. And so this is the summary. So whenever more than thousands, so you have to be very vigilant, and very aggressive management is needed to avoid the pancreatitis. So that diet, lifestyle, exercise has some amount of reductions, and ultimately the phenofibrates or insulin dextrose or omega-3 fatty acids and statins, maybe they depend upon the severity of the triglycerides. So the increasing prevalence of secondary causes of hypertriglyceridemia is recently been diagnosed, and the combined form is the most common form, and the very severe triglycerides is more commonly associated with the primary or genetic causes, and family history may be more important. And the non-HDL is a better CVD predictor than LDL in individuals with hypertriglyceridemia. So hypertriglyceridemia, always you do non-HDL, and drugs have promising role in mild to moderate cases. So with that I am concluding. Thanks for the kind attention.
Thank you, sir, for finishing up in time, and the forum is open for questions.
So we have documented multiple times and already tried medical management and impending any pancreatitis risk is there or lipemic serum, and so the consistently is very high, unable to manage with the other medical management. So you can reduce some point of time, then the baseline level may come up, then we can continue the medical management. So in very commonly we do at recently we have done one pregnancy case, insulin dextrose infusion, and we can use it as subsequent medical management. So it is like insulin infusions in case of DKA. We just reducing the baseline and then we can continue that. Otherwise, not routinely indicated in all the situations. Very rare conditions only we use. Yes. Yes, sir. Pardon, sir? The second question?
This is the flax seed.
So regarding, I don't have much experience with the seeds actually, and apology for that. And regarding the dosage, different dosage. So most of the mild to moderate cases, we can combine with statins, atorvastatin or rosuvastatin. So in such situations, many of the things may come in with 160 milligram. And 200 milligrams, if it is very severe cases, I prefer 200, but there is no head-to-head comparisons between the different dosage regimens and the reductions of the percentage of the triglycerides. And so it is an individual, but primary predominant hypertriglyceridemia, I prefer 200 milligrams and of the fenofibrate. Otherwise, in remaining situations, 145 and 160, there is not much difference.
Why then 145 is in the market? 160 and
So
200
DCG only we have to ask. Since some of the things, 1000 combination therapy, 1000 milligram metformin available, but combination no 500 milligram available. So some of the rational were beyond our scientific discussion.
Yes, sir. So in a routine general checkup, when patient comes with a hypertriglyceridemia report, at what stage we advise dietary modification and at what stage we have to start pharmacotherapy?
So more than 500 milligram definitely needed pharmacotherapy, and the remaining cases around 200 to 400 or 500, we can do dietary modifications and diabetic control if it anything. And again the family history and any secondary causes, if anything find out, then we give priority to treat the secondary causes, and most of the times some amount of reductions can happen. If it is persistently very high, then definitely pharmacotherapy is the one, but again it is not a single point measurements. So every day we will also learn everything. So each patients are different. So if it isn't consistently monitoring, consistently following up the patients and persistently high, then definitely but the 10-20% diet and lifestyle is having a role, but it is severe cases then pharmacology.
We thank all the three speakers, and next
you.
I think we'll have, for lack of time.